Hello, everyone. My name is Zehra. As the chair of ENDO Expert Hub, it's my pleasure to welcome you all to our very first conference update session. In this presentation, we're going to bring you a focused, clinically oriented look at what came out of ENDO 2026 in Chicago while it's still fresh. Before we dive in, I will briefly introduce my colleagues to you who are joining me today. Dr. Felona Gunawan is an assistant professor of endocrinology who is specialized in diabetes care, and she will be going over obesity presentations today with us. And Dr. Sadia Ali is an associate professor of endocrinology at UT Southwestern and clinical chief, and she will be also discussing some abstracts related to adrenal disorders. So before we actually get into details, specifics, I want to highlight that this year obesity talks dominated the conference, or at least I feel that way. But there was a lot of emphasis on incretin era obesity pharmacotherapies, and not just in the efficacy numbers, but in terms of mechanistic questions as to how these medications work beyond the appetite suppression and delayed gastric emptying. And also there were a lot of conversations regarding the trade-offs when it comes to change in activity and muscle mass. And there was some emphasis on newer drug developments and rare disease diagnostics and treatments. So we also had a session in regards to name change from PCOS, PMOS, the nomenclature change was also included in this conference. So now we will walk you through some of the 14 abstracts that we picked up from the conference. So Dr. Felona Gunawan is going to start with obesity talks.
All right. Thank you, Dr. Tekin, for the introduction. Let me just go ahead and get started here. So for the first study that we'll be talking about, this is the TAP-BAT trial, which looked at the impact of tirzepatide specifically on brown adipose tissue. So, tirzepatide has been around for a while now as a medication for diabetes and weight loss. And it's thought that the main effect that it has on weight loss is attributed to decreased intake, really, both through central mechanism of decreasing appetite as well as delayed gastric emptying. But in early kind of preclinical as well as small clinical studies, it's been shown that there's also a possibility that tirzepatide may have an impact on bone adipose tissue activity. So in this particular study, they did a 24-week randomized control trial that included 34 premenopausal women with obesity who were split into 50-50 cohort of those receiving tirzepatide versus placebo for about a 24-week period. And they measured activity of brown adipose tissue prior to initiation of medication, as well as at 24 weeks, using several modalities, including a cold stimulated FDG PET-CT scan, as well as a thermoneutral MRI. They also did an assessment of the patient adipose tissue biopsy, for which they did molecular testing. And what they found is that tirzepatide increased the proportion of participants with PET-CT detectable BAT activity from 41 to about 64.7%, whereas there was no comparable shift that occurred in the placebo arm. And this effect was seen across all the different imaging modalities that they utilized. And this has been an interesting finding because, typically when we think about patients who are losing weight, usually that then leads to a reduction in energy expenditure, including kind of BAT activation. Whereas here, we see that even though most of the patients are losing weight with a median weight loss of 13.5% with the medication, they still have this kind of BAT activation. Now, the study is pretty small, it's single-centered. And it is a very just homogeneous kind of cohort, just for all female premenopausal women. But I think at the end of the day, it's to kind of highlight an interesting new mechanism and how this medication, tirzepatide, can work. So that was an interesting study in regards to obesity treatment here. And then so for the second study, I'm going to be talking about a post hoc analysis of the ATTAIN-1 trial, which looked at the use of orforglipron in treatment of patients with obesity, and specifically the post hoc analysis to get cardiometabolic risk reductions with the medication. So orforglipron, also known as Foundayo, right, is the first oral small molecule non-peptide GLP-1 receptor agonist that's now has become available, and the fact that it's a small molecule non-peptide medication, unlike with semaglutide, it just give it this benefit of just being able to be taken without food, without water restrictions, once a day administration. And so in the ATTAIN-1 study, which is the parent trial, that one was a phase 3, 72-week randomized double-blind placebo-controlled trial that included 3,127 adults with obesity and overweight without type 2 diabetes. And they tested several different doses, with the max dose being 36 milligram, which is the equivalent of the 17.2 milligram dose that we have currently on the market. And so with the highest dose, produced a weight loss of about 11.2%. So it ranged really anywhere from 7.5 to about 11.2%. Weight reduction by 72 weeks, and about 54.6% of the patients on the top dose was able to achieve more than 10% weight loss. So what they did for this post hoc analysis was they basically looked at the cardiometabolic measurements that were taken for these patients in the study at baseline as well as at 72 weeks, and those includes things like waist circumference, systolic blood pressure, as well as cholesterol measurements. And so they were able to use those data to kind of plug into the cardiovascular as well as diabetes risk prediction equations. And the ones that they used was the Framingham as well as the Prevent risk calculator for cardiometabolic disease, cardiovascular risk calculations, and they used the enhanced cardiometabolic disease staging model for predicting type 2 diabetes risk. And so what they found is that, for the cardiovascular risk scores using both Framingham and Prevent, they found that, there was a risk reduction of about 6.7 to 10% that was seen in the cohort that was receiving the medication, whereas in the placebo group, they actually had an increase in cardiovascular risk from about 11 to 15%. And as far as risk for diabetes, the highest dose of orforglipron was associated with lower percentage of change, I guess, from baseline in the predicted type 2 diabetes risk of about 59%, whereas with placebo it was only about 10%. So definitely very kind of encouraging results with regards to predicting cardiovascular benefits from this class of medication. And it was interesting to note that, the magnitude of cardiometabolic improvement that was seen here was similar to what's been reported for both oral and injectable semaglutide obesity trial, even though, orforglipron doesn't reduce weight as much as semaglutide. So, semaglutide it's on the average of about 15%, and we have 11% here with Foundayo. But I think overall what the authors wanted to highlight was the fact that no matter really how you get there, overall, if you're able to get, greater than or equal to 10% weight reductions with any of these medications, that can lead to significant cardiovascular benefits for our patients. Right. And then the next study that I wanted to kind of review with you guys is this one, which is introducing one of the newer medications that's in the pipeline for treatment of hypothalamic obesity, which is one that's called bifamelagon. So as most of you are probably familiar with the fact that hypothalamic obesity is one of the more challenging type of obesity to treat in clinic, just because a lot of time it's really difficult to kind of control that impulse for overeating that can occur with hypothalamic obesity. And the most common etiologies for this would be things like craniopharyngioma or other pituitary suprasellar tumor, as well as damage that can happen from radiations or prior surgeries. And a lot of what happened is, the injury then leads to disruption of the melanocortin-4 receptor signaling pathway that then leads to this clinical phenotype of hypothalamic obesity. So what this medication does, bifamelagon, it's an oral MC4R agonist, which has the same target as another medication that's just recently again have a phase 3 study published called setmelanotide. So they worked on the same target, but the main difference is that bifamelagon is a once a day oral tablet, whereas setmelanotide is a once a day injection. And so what they presented here during ENDO was the result for the phase 2 study that included a 14-week of the double-blind kind of treatment phase, followed by a 38 weeks open label extension of the medication. It was a pretty small cohort of about 26 patients. And what they found, though, was encouraging. And, they did see that there was a BMI reductions ranging from 6.7 to 16.6% across the cohorts at 1 year. There was also a reduction in the hunger score for about anywhere from -2 to -4.8 across the cohorts. Side effects that were observed include things like nausea, vomiting, and diarrhea, as well as skin hyperpigmentations. And this is kind of similar to what was also seen with setmelanotide. And then the other thing that they noted was that, the reductions in weight that they saw were progressive over the treatment year, rather than this pattern of kind of like plateau then rebound that we got with some of the GLP-1s. Although I would say that, it is 1 year is still not a very long duration. So I think it'll be interesting to see what the data would show once we have a longer term study to look at the impact of the medication. All right. And then the final study that I wanted to share with you guys is with regards to the impact of taking GLP-1 medications on physical activity. So this study looked at data from the NIH All of Us research program that included kind of a large, diverse volunteer cohort who some of them were also wearing, I guess, Fitbit, to also had Fitbit-derived wearable activity data. And what's nice about that is the fact that it allows for kind of pre-post comparison of objectively measured activity rather than just relying on, self-reports of patients' physical activity. So from that cohort, there was about 1,950 adults with obesity who were prescribed GLP-1 receptor agonists, including things like, semaglutide, liraglutide, tirzepatide, and dulaglutide. And about 38% of those patients, so 753, had enough Fitbit data before and after treatment to be included in the analysis. The cohort was predominantly female, about 78% female with a mean age of 52 years, and 48% of them had type 2 diabetes. So what they found was that, the amount of daily step count actually fell from 5,000 to about 3,000 steps per day. But to 4,487 steps per day. So roughly about 560 steps per day decline. And the amount of moderate to vigorous physical activity also fell from about 28 minutes to 22 minutes. So a 6-minute per day reduction. And this occurred, alongside, not instead of, the successful weight loss that was seen. So I think this is just a good reminder that, when we're treating patients with obesity with this class of medication, just because they're losing weight does not mean necessarily that they're also increasing their physical activity, which is something that we definitely want to encourage patients to do, because as we know, this class of medication is also associated with loss of lean or muscle mass sometimes, which can increase the risk for things like sarcopenia. So it's always important to always also encourage our patients to make sure that they are increasing their physical activity or at least maintaining it while they're on this class of medications. And with that, I'm going to go ahead and turn it over to Dr. Tekin.
Yes, thank you so much, Felona. Now we're going to talk about diabetes topics. And we will start with a study that looked into GLP-1 receptor analog discontinuation and reinitiation in type 2 diabetes patients. So as you know, GLP-1 therapy in clinical practice looks much more like a start, stop, and restart more than taking a chronic daily medication for other chronic illnesses that we treat. This group from Boston looked into retrospective data from Komodo health claims, covering adults aged 18 to 64 with type 2 diabetes with a BMI over 25, who initiated either liraglutide, semaglutide, or tirzepatide with at least 6 months of follow-up. So discontinuation was defined as more than 60 days of gap in prescription refills. and reinitiation was any new fill after a discontinuation event. So in this study, 1 year discontinuation rate was 41.5 and 2 year discontinuation rate was 58%. And 53%, almost half of those patients who discontinued actually restarted in a year. And 65.9% of those patients reinitiated at 2 years. So study further looked into details as to who is at higher risk of discontinuation, and they found that Medicaid coverage, Medicare coverage, Black or African American race and ethnicity were all increased risk factors, as it's shown here. And also, lower discontinuation risk was, found in patients who were the prescription, if initiated by endocrinologists, it actually conferred lower risk of discontinuation. And higher reinitiation rates were also found in Black or African American patients, or in patients who had more than 5% weight regain after stopping. Also, tirzepatide users compared to liraglutide, as well as semaglutide users compared to liraglutide, had higher reinitiation rate. So lower reinitiation was associated with Medicaid coverage and Medicare coverage as expected. So I think this study really highlights the pattern of discontinuation, in fact, higher discontinuation and lower reinitiation among Medicaid and Medicare patients. That tells us that cost and access is a big barrier for these medications, rather than tolerability or lack of perceived benefits. So this was a very interesting study. And then the next study that I wanted to highlight was a study that looked into diabetes burden and mortality in solid organ transplantation. As we know, solid organ transplant recipients are known to be at risk of developing diabetes, both because of glucocorticoid use or other, immunosuppressive treatments, including calcineurin inhibitors. But there wasn't any study that looked into, comparing different organ types, head-to-head study as to how diabetes affected survival in these groups. So, for example, a kidney transplant recipient's physiology and diabetes risk profile is not the same compared to the lung recipients, and this study, showed that pretty substantially. So the study included multi-organ analysis of over 800,000 patients. The data was received from UNOS, organ transplant directory. And so it included, majority of those patients were, as expected, kidney transplant patients, more than half of them, 441,000 patients, followed by liver transplant patients, 264,000, followed by heart, 75,000, and lung transplant recipients were 42,000, followed by a small number of pancreas and intestine transplants. Patients were stratified in this study by diabetes status, pre-existing versus new onset transplant after new onset diabetes after transplant, known as NODAT, and mortality was tracked out to 10 years. This actually, the transplant recipient information was from 2003 to 2021. So the study takeaways is that the highest diabetes mortality was in kidney transplant patient, and the lowest was in the lung transplant patient, with no statistically significant increased mortality, highlighting the difference in the disease pathophysiology processes. And it also showed that the new onset diabetes after transplant rates were actually sustained beyond first year of transplant, which is contrary to the common assumption that the NODAT risk is front-loaded, to the immediate post-op transplant period. So basically, takeaway from this study is that the diabetes screening and management needs to be organ specific and sustained indefinitely post transplant, not just concentrated on the first 12 months. And limited resources, including endocrine, maybe referral, should be utilized more in patients who need the care most, in this study, as highlighted, kidney transplant patients versus lung transplant patient, for example. So the next is the adrenal section. Dr. Ali is going to take over these studies and will moderate it.
Thank you, Dr. Tekin. Okay. So I'll be focusing more on the adrenal studies at ENDO 2026. There were quite a few interesting case reports and a small series for patients with non-classical congenital adrenal hyperplasia that were there, and use of crinecerfont, which is marketed as Chronicity. So I'll go over the case reports first, and then collectively we'll talk about what's the clinical takeaway for these. So this one was a case report for a patient. They reported an 11-year-old female who had non-classic congenital adrenal hyperplasia from 3-beta hydroxysteroid dehydrogenase deficiency. This girl presented with premature puberty, and she had elevated 17-hydroxypregnenolone levels and DHEA levels. She was treated with crinecerfont Chronicity, and she was started on it at age 10 years. And this helped improve both biochemical markers for her, and clinically, it also helped with her puberty. So what they noticed with after treatment was that levels of both 17-hydroxypregnenolone and DHE levels both improved, and clinically, her puberty, it continued to progress normally but was not advanced. And this was important because at this stage, you also don't want to suppress normal pubertal development. At the same time, her hyperandrogenic manifestations, they appeared to be controlled. And apparently, the safety aspect, the patient tolerated therapy well with no symptoms that were suggestive of adrenal insufficiency. I'll move on to the next one, and then we'll collectively talk about use of chronicity in these patients who have non-classic CAH. So this is another patient that was actually reported from some of my colleagues here. This was also a case report. This was a patient with CAH who had 17-alpha hydroxylase deficiency. And this was a first case report that they use chronicity in this patient. This was a 26-year-old woman who had classic 17-alpha hydroxylase deficiency. She had long-standing severe hypertension, and she had failed multiple antihypertensive therapies, including spironolactone at quite a high dose, 600 milligrams daily. She was offered as part of the treatment bilateral adrenalectomy, which was declined by the patient. And then at that time, they decided to use off-label chronicity for this patient. And when this patient was started on chronicity, she was on 100 milligrams twice a day of chronicity. They noticed a marked improvement in her blood pressures, which dropped from 150s systolic to 120s diastolic to 120s, 130 systolic to 80-90s diastolic. There was also a marked improvement in her biochemical markers. Her deoxycorticosterone, pregnenolone, and renin levels, they all improved. So with this medication for use of chronicity at the end of 1 year, patient they were also able to gradually taper her glucocorticoid dose, and the blood pressure improvements were remarkable in this patient. So why does this make sense biologically? What is Crinesen for? I always mess up the name. I don't know why we have to use such complicated names for our drugs, but Crisenfort, this is what does it do? It is TR3. It is a CRF1 receptor blocker. What does this do? This is involved in ACTH secretion, and it's involved in the upstream mechanism. So when it blocks the CRF1 receptor, it reduces the ACTH secretion. And because ACTH, this is an excess of ACTH, this is a common driver for adrenal steroid overproduction. This is one mechanism that overlaps the multiple different forms of CAH we have. However, the most common form of CAH is 21 hydroxylase deficiency. So this drug has been approved, has only been studied on randomized controlled trials for 21 hydroxylase deficiency and is approved for 21 hydroxylase CAH deficiency patients. But in theory, if you control the ACTH, potentially this can also work in other non-approved forms of CAH deficiency. And to me, these studies were important because they kind of provide an early proof of concept for these ideas. And it is sometimes not possible for these rare form of CAH. You don't have enough patients to kind of do a big randomized controlled trials, but I think this is kind of important for hypothesis generation. So for me, clinical takeaways are that, it does provide for certain populations, for certain patients with these rare forms of CAH deficiencies. These are drugs that we can potentially consider because they work on lowering that ACTH pathways. So that's the main thing that comes across to me, that we can, they may be beneficial across a wider range of CAH subtypes. Moving on to now beyond the corticosteroid pathway. This, I think, was an important study that this was single center this was a single center retrospective study of 13 patients. They studied dotatate therapy, which is the Lutathera therapy, in patients with metastatic and inoperable pheochromocytomas and paragangliomas. And this was important. Why this was important? Because, we all have patients with metastatic pheochromocytomas and paragangliomas, and they remain challenging tumors for us to treat. And many of these patients, they often have progressive disease. They have a lot of symptoms related to catecholamine excess. And for these inoperable cases, we have limited systemic treatment options. And a little bit of background on the 177 Lutathera dotatate therapy. This is well established in patients who have neuroendocrine tumors. And there is a lot of real world use of this therapy and these neuroendocrine tumors, but we don't have enough data. We don't have much data for this therapy in patients with metastatic or inoperable pheo or paragangliomas. So this group of authors, they reported single center retrospective data on 13 patients who had metastatic and inoperable paragangliomas that were treated between 2018 to 2025 at their center. A few of these patient characteristics that stood out to me was that 58% of these patients, they had STHB mutation. And STHB mutations, as endocrinologists, we know this behaves more aggressively. So this study cohort was particularly high risk. That's what stood out to me. And about 77% of these patients, they had markedly elevated plasma metanephrines, like greater than 4 times the upper limit of normal for the metanephrine. So they were pretty symptomatic patients. And they used PRRT therapy as first line in 60% of these patients, as this was used as first line. And majority of these patients, they completed all 4 planned treatment cycles, which is pretty good response, which is pretty good. And then the efficacy that they reported, which was pretty good, and that was the headline for me that stood out for me. 83% of these people was shown to have disease control. And if you kind of break it down in this slide over here, you can see 58% of them, they achieved stable disease. Then 25% they achieve partial response, and 17% of these patients they experience disease progression. Now, what does this mean in terms in practically speaking? In patients who have rare tumors like metastatic paragangliomas, disease stabilization itself, it is a meaningful outcome. And we necessarily, in these patients, when we are managing them, we don't necessarily expect a dramatic tumor shrinkage in every patient. So the stable disease to me also stood out as something meaningful. All right. So yeah, this was the most interesting thing that stood out, that over 83% overall disease control in these patients. And another thing that really stood out to me as an endocrinologist was the safety highlight here. And this was very interesting again. When we consider PRRT in patients with paraganglioma, especially a lot of these patients, they have biochemically active disease with a lot of catecholamine secretion. There's one concern that can be challenging is, would it provoke catecholamine release when these cells are dying? And the fear would be, would that cause radiation, then radiation-induced tumor injury, and lead to hypertensive crisis, arrhythmias, or catecholamine surges in these patients? So this was an important part that stood out to me, that they did not, and it was reassuring that they did not see any hypertensive crisis, no catecholamine release syndromes, despite the baseline metanephrine levels being high. The treatment-related adverse events that were reported, most common were the hematologic toxicities, then grade 3 and above myelosuppression in 15% of the patients. And then renal radiation exposure was also there, but it was generally within acceptable limits with absorbed kidney doses, mostly beyond 23, less than 23 grays. And about 30% of the patients, they did ultimately underwent retreatment, suggesting that some patients derive, sufficient benefit to justify giving them additional therapy. Now, how does this kind of fit in with our current practice? I think this kind of, to me, it supports what we already know for a lot of neuroendocrine tumors, that data that has already been observed, that these patients with neuroendocrine tumors that have somatostatin receptors, they can derive a meaningful benefit from PRRT. And this is where it can be beneficial, and we can consider this to be safely administered in our patients who have inoperable paragangliomas or pheochromocytomas that have significant biochemical activity. So for me, it is reassuring that this can be a safe treatment option for patients who have metastatic or inoperable disease with highly active catecholamine tumors, and those that are not responding to conventional therapies. This could be a safer option. But important for it to be done at a place that is used to doing this treatment, and still to watch out for any possible catecholamine surge. All right, so this was also interesting. We cannot finish any conference without AI. And how do we benefit from AI in endocrinology? And this I thought was an interesting study. So this was a study on AI-based screening for primary aldosteronism. And This was basically what the investigators did. This was done at Mayo Clinic, and the researchers, they developed an AI model that used routine electronic health record data. And what they did was the important thing was they did not require any special lab testing, imaging studies, or additional visits. They developed this data, they developed this AI tool, screening tool, and they trained this model to predict patients at higher risk of primary to predict patients who would with hypertension at high risk for primary aldosteronism. This model was trained on more than 22,000 patients in their database. And in that database of 22,000 patients, about 1,800 of these patients, they had confirmed primary aldosteronism. And the important thing was because it uses information that's already available in the electronic health record, the system can theoretically in the background run quietly, and it can continuously assess the risk in these hypertensive patients. And it does not require additional resources or burden on the clinician to order more labs or tests or visits. And the results for this, it showed that, the initial ones, area under the curve, was 70, it showed a 71% sensitivity at 30 days, and at 1 year, 67% sensitivity. And then, so one thing that's important to kind of recognize here is that these results, they're not, these results are not accurate, that this 0.7% area under the curve, it's not accurate enough to diagnose PA. And diagnosis of primary aldosteronism is not the goal here. The goal here is triage. And when they use a threshold that prioritizes sensitivity, the model identified about up to 90% of patients with true PA cases. And at the same time, it reduced the number of patients needing further evaluation by focusing attention on patients, hypertensive patients, with a higher risk for PA rather than everyone for PA. So in other words, it kind of narrows the funnel. So can we move on to the next slide? Oh, actually, let's go back. This is the only slide. So for me, what do I think is the most important takeaway from this slide? To me, it highlights the practical use of AI in endocrinology. Rather than replacing our clinicians or replacing diagnostic testing, we can use AI to better identify patients who may otherwise be overlooked. And to me, this does not replace the Endocrine Society guidelines for diagnosis of AI, but rather, and it does not either replace the screening guidelines, neither does it replace the confirmatory testing, but it simply helps us answer, like in this big group of patients, we have a large number of United States population who has hypertension, about 48%, which is like roughly half the population, right? And in that 48%, it is roughly estimated like 20% of these people may have primary aldosteronism. So if you look at it, that's a very large number of patients. We don't have enough clinicians and specifically enough endocrinologists to kind of screen all those patients. So that's where AI helps us out, and it helps us answer this question, like who should we test first in these patients, and kind of screen the patients that are low risk and puts the patients who are high risk to be screened early. And that's where I think is the real value of AI here. But I do think there is a limitation here, and the limitation here is the generalizability. because this study was done at Mayo Clinic. And what is Mayo Clinic? Mayo Clinic is a large tertiary care center where we have a very select group of referrals that get sent. So can we generalize it to the real world population with community practices or primary care settings? Probably not. I think this model needs to be validated first in the generalized setting, in the real world primary care setting, before we generalize it. So that was my take on the adrenal studies from ENDO 2026. Over to you, Dr. Tekin. Thank you.
Thank you, Dr. Ali. Now we're going to move on the pituitary section, and I wanted to bring up Acrobat Advanced Study to your attention. This study, before we actually start discussing about it, I want to give you a brief background regarding the paltusotine pivotal Pathfinder 1 and 2 studies. Paltusotine, branded as Palsonify, is a once-daily oral non-peptide somatostatin receptor ligand, FDA approved for acromegaly after inadequate surgical response or when surgery is not an option. And in the first two pivotal studies, Pathfinder 1 looked into patients who are already biochemically controlled on injectable SRLs, who then switched to oral paltusotine. And then in the Pathfinder 2 study, the investigators looked into patients who were not controlled at baseline. So in this study, it was similar, I think, to Pathfinder 2 patient population. The patients were actually not optimally controlled on combination therapy. So it's basically looking into patients who are already controlled, who are difficulty controlled. Now they're not even controlled on or suboptimally controlled on the combination therapy on the Acrobat advanced study. This analysis, including 25 patients who received at least one dose of cabergoline on top of paltusotine, and these patients were followed up to 4 years. And cabergoline dose in this study ranged from 0.25 to 7 milligram per week, and it was titrated individually. And 4 patients also received pegvuzumab as an add-on therapy. So if you look into study results, it showed that 84% of these patients actually had IGF-1 normalization. And the safety profile was, similar to other studies, but most common adverse effects reported as arthralgia, headaches, diarrhea, and there was only one serious drug-related adverse event was reported, cholelithiasis. Basically, this study highlighted that individuals who already need combination therapy at baseline might be offered from convenience standpoint also an oral combination therapy with paltusotine with cabergoline. So now moving on the next study, actually we're now switching the thyroid studies, which I think were very exciting. So we'll talk about first a preclinical study. This is ETH001 molecule. This is a novel treatment, TSHR monoclonal antibody antagonist for both Graves' disease and thyroid eye disease. So this medication, actually, a molecule, is mechanistically distinct from the existing IGF-1 receptor antibodies. The one that we have available, teprotumumab, Tepezza, and it's also emerging competitors that I will be talking about in a bit. They work by targeting the downstream effect from the orbital fibroblasts. So they block a signaling pathway that amplifies the inflammatory and tissue remodeling process in the eye socket. But they don't really address the actual autoimmune driver. So this molecule basically is a half-life extended monoclonal antibody directly against the thyroid stimulating hormone receptor itself. So basically it's blocking the driver of this disease itself, which is thyroid, stimulating antibodies. So that can basically treat the root cause of both Graves' disease and at the same time, thyroid eye disease, because these receptors are targeting thyroid and orbital tissue at the same time. So this preclinical data showed that this molecule produced complete blockage of autoantibody-mediated TSH receptor activation across all patient serum samples tested, which is really exciting because, patients can actually have different antibodies. So this shows that it works for various antibody subtypes. And it also demonstrated, in vitro studies that M22 induced hyaluronate and IL-6 secretion from thyroid eye disease patient-derived orbital fibroblasts. So what does that mean, basically? M22 actually is a reference monoclonal stimulating antibody. So it's similar to the thyroid stimulating antibodies. Basically, they took the orbital fibroblasts of these patients with thyroid eye disease, and they looked in the in vitro studies, and it's been shown that these antibodies were blocked. This antibody induced production of the molecules, hyaluronate and IL-6, were blocked. So this molecule is formulated as a subcutaneously administered half-life extent technology with infrequent home dosing, and they're planning actually to develop an auto-injector for that. So the human studies, or safety or efficacy data is not there yet, but this is an exciting, basically conceptual data that's gonna have a great clinical implications if it actually goes into clinical practice, because it targets the underlying pathophysiology of the disease. Second abstract that I wanted to highlight, this is also the new antibody for thyroid eye disease, they MHP018A. So they, published the results from phase 1 and 2 trial. Again, this is a very exciting area of development in thyroid field. The only first and only available targeted therapy we have is teprotumumab. Just to give you a brief background in their, pivotal OPTIC trial, it showed that teprotumumab resulted in 83% of proptosis response at week 24. Now we have a couple of studies coming up and that are also showing similar results. But I want to mention that teprotumumab has a well-documented hearing toxicity, and then there is an aim actually to reduce that toxicity in the upcoming trials. Now, I would say some of the names, Amgen has a sub-Q teprotumumab reformulation. As you know, Tepezza is an IV infusion. With the sub-Q administration, it's been hoped that it will be more convenient and accessible to our patient. So Amgen's sub-Q reformulation posted 77% of proptosis response at week 24 in their phase 3 trial. And there is a Celerine's, drug, lonigutamab, that's a conventional IgG1, targeted therapy, and that showed 50 to 67% proptosis response in their trials. And there is also Gradient's IV, again, another IV drug that has been just approved by FDA actually after the ENDO Society's conference on June 26th of this year. And brand name is Lumvoe. So now this drug that I'm showing you here, presenting you here, actually has a slightly different mechanistic effect. It actually targets different portion of the IGF-1 receptor, and it's formulated as subcutaneous at-home administration. So in this clinical trial, there were approximately 100 patients with both active and chronic thyroid eye disease. And they received the recommended phase 3 trial dose of 450 milligram every 4 weeks. And the study reported actually even at week 12, proptosis response rate was 81%, which is pretty robust. And then, for chronic thyroid eye disease, proptosis response was 76%. And there was a significant diplopia response, 61% that was reported. There was a marked improvement basically in patients with diplopia. 61% of them has achieved clinical activity score of 0 or 1, essentially, inactive inflammatory disease at that point. So in terms of safety profile, no severe or permanent hearing damage was reported amongst these patients, and then hearing related, side effects were considered mild. So yeah, this is an exciting clinical trial, and phase 3 trials are ongoing in China, and then global enrollment is planned for later this year. So going on the next topic, I want to discuss about the Europath's study, the final pathway phase 3 trial results. So as we know, hypoparathyroidism results from PTH deficiency causing hypocalcemia and hyperphosphatemia, and conventional management includes calcium and vitamin D, active vitamin D supplementation. Which can actually lead to long-term, complications such as, renal impairment, nephrocalcinosis, etc., and actually impaired quality of life in many of our patients. So in this study, basically, just to give you a background, Yorvipath, paclitaxel is a long-acting PTH prodrug, which was FDA approved in August 2024. As basically a hormone replacement therapy rather than symptomatic, management. And this was their extension study trial results, actually going on to almost 3.5 years. And so I think the results were very impressive, robust when it comes to independency from calcium. It was 96%. 89% of these patients achieved normal calcemia, and none of these patients actually required active vitamin D use. And there was actually 11 point GFR improvement in this population, along with some other benefits when it comes to stabilizing bone turnover markers or improvement in, disease scores in these patients. As expected, 24-hour urine calcium normalized because they were actually not requiring calcium supplementation. And there was a significant improvement in patient-reported outcomes, which was sustained throughout the open label extension. And most adverse effects were reported as mild or moderate. So yes, I think this is a very promising long-term replacement strategy for hypoparathyroidism. Now, going on the last topic, we just want to highlight studies regarding reproductive endocrine. So first study that I want to highlight is actually regarding the testosterone misuse that we commonly encounter in our clinical practice. So this was a study, that looked into, from University of Michigan, looked into patients, 200 patients who were diagnosed with hypogonadism and treated with testosterone. And they wanted to check whether these patients had, prior to initiation of therapy, had proper workup that was, suggested in the guidelines. So what guidelines recommend, Endocrine Society guidelines recommend, is that patients should have at least 2 separate low morning testosterone measurement, along with gonadotropin, LH and FS measurement to differentiate between primary and secondary hypogonadism. And also they recommend that patients should not have any contraindications to therapy. So the highlight of the study is that unfortunately only 12% of these patients had they met the criteria. So all the participants had at least 1 testosterone level checked, but the 2 level properly timed plus gonadotropin measurement according to guidelines were done only in very few patients. And looking into patient characteristic, mean age was 52, and 63% of these patients were obese, and actually almost similar amount, 59% of these patients had documented sleep apnea, and there were other comorbidities commonly seen, and 4% had prostate cancer prior to prescription. And when it comes to prescriber distribution, majority came from primary care physicians, and the lowest amount was prescribed by endocrinologists. And again, I want to highlight that this is a study done at University of Michigan, and not to include patients who get on testosterone at low T centers, outside of institutions, or tertiary centers. So again, this study, I think, highlights that there is definitely an overprescribing of testosterone for non-specific symptoms without rigorous workup. And then there's more effort needed in terms of like educating the primary care physicians, or other specialties outside of endocrinology. So then the next slide that I want to bring up. Yes, and again, there was a session regarding the PCOS being renamed to PMOS. And so just to give you a background, on May 12th of this year, a coalition of 56 patient and professional organizations, including Endocrine Society, they actually came up with this name change. They formally renamed polycystic ovarian syndrome to polyendocrine metabolic ovarian syndrome. So an Endocrine Society actually described this as the largest initiative ever undertaken to rename a medical condition. And again, PCOS, formerly known as PCOS, PMOS, affects more than 170 million women worldwide, roughly 1 in 8. And then the name change basically, has taken place to shift the emphasis from ovarian single organ disorder to more metabolic, endocrine, reproductively multidimensional disease. As the name implied in the past, that, what appears on the ultrasound as cysts, actually, we know that are not cysts. These are arrested follicles. They're partly developed eggs that stop maturing. So again, the name change is hoping that there will be more emphasis on the underlying pathophysiology with insulin resistance. And, we know that there is definitely increased risk of metabolic disorders, including type 2 diabetes, cardiovascular diseases, along with reproductive, effects. So with that, we conclude our first post-conference update session. Thank you, everyone, for joining, and hope you can join us in our future episodes. Thank you, everyone.